All right, welcome everybody to our first session in National Infertility Awareness Week. Today we're going to be covering chronic conditions that can contribute to infertility with Dr. Jeelani, our wonderful REI here. And let's get started. So I just want to give you a little background if you haven't heard of Kindbody, if you don't know what we do. We are on a mission to make reproductive health and fertility care more accessible to all. We serve patients directly and then through employers. So if you do work for a company, they may have a fertility benefit with Kindbody. You should definitely ask. And if they don't, you should ask them to have one because it's so important. That's how and you'll learn more about this on Thursday, that's how we increase access to care. It's very important that everybody has access to this essential healthcare. So see, these are some of the services that we provide: fertility consultations and testing, egg and sperm freezing, embryo freezing, IUI, IVF. Dr. Jeelani will go over the details of these procedures, but just so you know, these are a lot of the things that we can provide to you, as well as counseling and support and holistic services through Kindbody 360, mental health support, nutrition, third-party and donor support. So please, we're a holistic healthcare company. We want to make sure that everybody gets the care that they need in all areas. So feel free to ask any questions about any of the services that we provide. Okay, now let me introduce our wonderful host. So our board certified reproductive endocrinologist and infertility specialist, Dr. Roohi Jeelani. She's also our chief medical officer. We're so excited to have her here. It's a real treat because she's busy. So let me just throw it over to you, Dr. Jeelani. Take it away.
Hi, everyone. Thank you for having me. And I'm so honored to kickstart this week with you and speak about something that's very near and dear to me, like chronic conditions that can and have impacted infertility. So super excited, both as a patient and as a doctor, to talk to you about this. So PCOS and underlying chronic conditions can really impact not just your overall health, your longevity, but your fertility. And it can impact your fertility from all aspects, whether it be lack of ovulation, whether it be lower egg quality, whether it be implantation and miscarriages when it comes to endometriosis, or preterm delivery, birth, and pregnancy complications as it relates to fibroids. So we're going to talk about how do you diagnose these, what are the signs and symptoms to look out for, how we can help you test these, and then what are the treatment options available for you all. So fun facts, I don't know if they're fun, but I like to learn about my body, is that 1 out of 6 adults worldwide will suffer from infertility. The 3 most common conditions or chronic conditions that we see are: number 1 is PCOS, second is endometriosis, and third is fibroids. A lot of these are often misdiagnosed also. So I'll see a lot of patients who are coming for a second or a third opinion, and they're saying they were told that they have unexplained infertility. But when you actually look at the root cause and when you do testing, you find out that they have underlying endometriosis or PCOS. And it's not just me. When you look at unexplained infertility, oftentimes after these patients start doing treatment, they have underlying endometriosis. And just to recap, someone asked, what is PCOS? So I think that's important to touch on now. PCOS is polycystic ovarian syndrome. Polycystic ovarian syndrome is a misnomer. So it's not cyst, but it's actually a lot of eggs. And it's the most common reproductive disorder. So 13% of patients that we encounter suffer with PCOS, and 90% of those 13 are anovulatory, meaning they don't ovulate. Up to 10% of the patients that we see will suffer from endometriosis. And endometriosis is when your uterine lining actually grows outside of your body or your uterine body and in your fallopian tubes, on your ovaries, and your belly. They typically present with heavy cycles, pain with intercourse, associated bowel symptoms, and 50% of patients with endometriosis actually suffer from infertility. 70% of patients will have a fibroid in their lifetime, and 10% of them will impact their fertility. And then if you look at the subset of patients it impacts, Black women are more impacted by infertility, Latin Americans, and then Asians. So what are the signs and symptoms, and how do you know if you have one of these underlying disorders? PCOS, you need to have 2 out of the 3. Typically presents with irregular cycles, lots of eggs on your ultrasound, excessive either body hair or acne, and then weight gain. Typically it's central obesity, so metabolic syndrome. And then with endometriosis, it's extreme pain with your period. Oftentimes patients describe premenstrual syndrome, pain with sex, pain with bowel movements, or changes, even constipation and diarrhea as your cycle varies. Fibroids typically present with heavy periods, painful periods, a lot of dull pelvic pain or pressure. And then because this is almost a foreign object in your pelvis, you feel like early pregnancy symptoms, like something's pushing on your rectum or your bladder. So frequent urinating, hesitancy, or trouble urinating if it gets that big and if it's in that area. So we'll start with PCOS. So let's take a quick quiz and then let me know if you've answered yes to any 1 or 2 of these questions. Typically, you see excessive hair growth on your body. I'm going to share a personal story here. I have PCOS, and people would be like, "Oh, are you hairy?" And my first question was like, "Well, I'm Indian. Of course I'm hairy." So as a doctor, I've learned, let's rephrase that. Not just are you hairy, right? Because it's very ethnicity dependent. It's, do you have a testosterone-driven hair growth? So I always say, do you have hair where a female shouldn't have hair? Knuckles, upper lip, chin, in between your breast line, a wider pubic line. And if you've answered yes to that, even if you may not be hairy, but if you have testosterone-driven hair growth, that's a yes. Do you have acne? And I don't have acne or cystic acne, but I do break out. Usually you notice acne in your cheeks. So not a hormonal pattern, not acne like when you randomly get a period, but more just blocked and oily skin. And do you get non-pattern acne? And then weight gain or difficulty losing weight that can go with metabolic syndrome. And then irregular cycles. And by irregular cycles, I mean periods greater than 35 days apart. So I also learned this from being a doctor, that I asked one of my patients that, "Oh, do you get a regular cycle?" And she said, "Of course." So then when we were going to get scheduled, and I was like, "Okay, when's your next period?" And it was like 3 months later. And it was a aha moment to me, because I realized I should be saying, do you get a period every 30 days? And if it's not plus or minus 5 days, so if it's greater than 35 days apart, then that means there's something going on, like no ovulation, and you have irregular cycles. So if you've answered yes to this, any of these, schedule a fertility checkup with a local kind body doctor or with a local kind body office to figure out what's going on with your fertility. So PCOS is the most common reproductive disorder that we see. It commonly can present with irregular periods, and it can affect 1 in 10 women. We use what's called the Rotterdam criteria. That is the most current diagnostic criteria for PCOS, and you need to have 2 out of the 3: irregular cycles, biochemical or clinical signs of hyperandrogenism. So even if you don't have any of these features that I just described, if you have high testosterone, you can fit this criteria. And you need multifollicular ovaries on your ultrasound, meaning greater than 12 eggs on 1 or both ovaries. So how does PCO affect infertility? So if you noticed earlier, I said 90% of PCOS patients will not ovulate. But even if they ovulate, then sometimes there's an egg quality component from that constant testosterone exposure. So the first treatment that we do, if your tubes and sperm are okay, is we help you start ovulating, meaning an egg has to grow, release, and wait for the sperm to get fertilized. In PCOS patients, the egg is at its baby stage, so it just sits there and it never grows and releases, meaning no egg, nothing to fertilize, and then no pregnancy. So do all patients with PCOS need fertility treatment? No. If you're anovulatory PCOS, then yes, you need help to help regulate ovulation. Next question is, even if you ovulate and you have an underlying cause of PCOS and you're not pregnant, you should still seek help, because when you look at PCOS, it's a chronic inflammatory condition which can affect all aspects of your fertility journey. If you're spontaneously pregnant with PCOS, then you do want to follow up with your OB/GYN and hope, fingers crossed, for a happy, healthy pregnancy. So how do you know if you're ovulating or not? Remember, ovulation predictor kits are not as useful in PCOS patients because PCOS tend to have high LH. And the ovulation predictor kit also checks for LH. So that makes the period tracking apps or these ovulation predictor kits unreliable for patients with PCOS. So what we typically do for a PCOS patient is we help them ovulate by giving them a fertility pill. We track it with blood and ultrasound, and then we track it for progesterone post-ovulation. Okay. So ideally, what you want to do is you want to understand and analyze the root cause. If it's ovulation, then you want to help resume that, but also look at your gut health, look at your anti-inflammatory. So I always tell my patients, there's all aspects of PCOS. There's your blood sugar, there's your thyroid discrepancy. That's what you can have other hormonal imbalances. Sometimes we have TPO, that's thyroid peroxidase antibodies positive. Movement is super important for PCOS because we tend to have metabolic syndrome. Stress, good quality sleep, low processed food is what I say. Mediterranean diet is typically best for fertility. And then if you're PCOS and overweight, losing or reduction in weight or BMI by about 5% can also help improve outcomes. So we typically start with something called ovulation induction to make sure you're ovulating. Letrozole is currently the drug of choice. You may have also heard of something called Femara. We track the egg for growth, then we trigger it, that what makes it mature or release, and breaks it into half of you. If there's no underlying sperm component, then you could do timed intercourse. We'll tell you when to have sex. We also assess your blood sugar levels, and stuff like metformin or inositol can help us regulate that. Sometimes we add in an insemination if we're having trouble timing intercourse or if there's a mild male factor. And then ultimately, if none of these work, we talk about in vitro fertilization or IVF. So let's move on to endometriosis. Endometriosis is inflammatory as well. So let's see if you answer yes to any of these questions. If you answer yes to 2 or more, then I think you need to set up an appointment with Kindbody as well to get tested. Typically, endometriosis is a diagnosis of exclusion. It typically presents with heavy, painful periods, a lot of pelvic pain or pain during intercourse, and then frequent urination, constipation, backaches, or leg pain. And then recently, I've noticed patients also talk about a correlation with certain foods or diets that are pro-inflammation that can worsen, or they feel their endo a lot more. So endometriosis is basically seeding. It's when your tissue from your uterine lining tends to grow outside of your urinary cavity. It can implant in the tubes, it can implant in the ovaries. It presents with back pain, pelvic pain, heavy bleeding. And basically, if these implants are in your body, these areas start to bleed, and that's why you feel this inflammation or adhesions in your pelvis or even in your uterine or abdominal cavity. So how do you diagnose endometriosis? The gold standard is a diagnostic laparoscopy, which is a surgery. That is the best way and the only proven way. We also do it via MRI or ultrasound because sometimes you can see these cysts on your ovary, and we call them chocolate cysts, or basically that blood, it pools and it collects and it forms a big, dark, heavy cyst on your ovary. That's an endometrioma. We can also do it through pelvic exam or an abdominal exam, and sometimes you can see these seedings. Okay, so endometriosis is inflammatory. Imagine if your ovaries are sitting in this hot tub, and our ovaries are filled with all of our eggs that we're born with. So if all of this inflammation in this hot tub are kind of pooling around that ovary, it can decrease ovarian reserve and quality. So you notice that even when we do IVF and we get eggs from patients with endo, they have lower fertilization, lower blast development, and lower implantation. You have a big attrition as you go through IVF and also as you go through life, meaning the egg quantity and quality are lower compared to your age-related peers. You also notice that our tubes can be damaged when we have endo because this inflammation can wrap around the tubes, which can cause pooling of this fluid, which can cause your tubes to be dilated and damaged. And that's called a hydrosalpinx, or water in your tube. Okay. Typically, treatment, if you're not trying to treat the fertility aspect of it, we say Motrin 2 days before the onset of your period because you want to try to regulate your prostaglandins and decrease the inflammation. You can use birth control to shut down your ovarian function, or we can try progesterone only if you're worried about feeding it with estrogen or a combined pill. If we have severe suppression or pain, we want to suppress it with stuff like Depo-Lupron or surgical excision. Ultimately, if nothing works and you're done building your family, we can talk about removing your uterus, tubes, and ovaries. That can help kind of shut down hormonal production, but you want to make sure you're done having kids and you're of age, because remember, even though we're not trying to get pregnant, or we may not trying to be getting pregnant, we need the ovaries because estrogen is really important for your heart health. It's important for your bone health. Okay, let's talk about fibroids. So let's see if any of you guys answer yes to these. Typically it presents with really heavy bleeding, lots of cramping, and pelvic pain. They typically tend to have really long cycles because this uterus is trying to get rid of the fibroid. So it keeps cramping and bleeding, cramping and bleeding. And you also have irregular bleeding, meaning throughout your cycle. You may also experience pain during intercourse, and you also experience what's called a mass effect because there's a pelvic mass. You may have frequent urination, constipation, and changes with your bowel patterns. So fibroids are, in general, you see a much higher risk in Black women. They think it's usually genetic or epigenetic, and then they can have detrimental effects on reproductive outcomes because remember, it's a mass where a baby should belong. So what we typically see is sometimes, depending on the location of that fibroid, a higher miscarriage rate, and it's definitely associated with more pregnancy-related complications like preterm labor and delivery, more abnormal presenting babies, malpresentation, and therefore a higher C-section risk. Fibroids impact 20 to 50% of reproductive age patients, and they tend to be higher in women of color. And even I'm Indian, we tend to have a higher incidence of fibroids as well as we age. So how do fibroids impact fertility? They don't, surprisingly, always impact fertility. They just can grow as you're trying to go through this journey. If they're in the actual cavity where the baby is trying to land or implant, then it can have a negative impact on your fertility. So you really want to understand the location, the type, and is it impacting your fertility and your ability to implant or fertilize. So we typically do a pelvic exam and an abdominal exam to check for the location. We can also do an ultrasound or an MRI. We also do a saline sonogram, which is a water ultrasound. So we fill the cavity with water, and we want to make sure that fibroid is not impinging, is the word we use, in the area where the baby would land. Treatment options are either suppression, like birth control or Depo-Lupron. The medications are the Depo-Lupron. It can shrink the fibroid before you want to transfer or try to get pregnant. Surgical options are a myomectomy or a laparotomy or a laparoscopy or a robotic myomectomy, depending on the skill set of your doctor. And if patients are unable to get pregnant due to fibroid, we can offer various treatment options, whether we try to shrink it and then see if we can get you pregnant, or some of my patients have really, really bad fibroids, and we talk about using third parties like a surrogacy route. So what can you do? Initially, you want to have a one-on-one consultation with your fertility specialist. You want to take a deep dive into your medical history, your family history, and most importantly, family goals. What does that family look like to you in an ideal setting? You also want to make sure that you're talking to your doctor about a personalized plan and the next best steps for you. I always wanted to know the next. I would start and I want to know my next. So first, we want to get you a consultation set up, and then we can talk about what that fertility journey looks like for you. So there's multiple options. We can start with ovulation induction. You can add in an IUI. There's IVF. There's egg donation, sperm donation, and then gestational surrogacy. So how you get started is you go to kindbody.com/activate. It's make sure, like Sydney was saying, you talk to your employer if you have fertility benefits. We do an amazing job of doing what's called a verification of benefits to make sure you have coverage. If you don't, go to your HR. I have plenty of patients who've gone back and tried to advocate and get fertility benefits such as Kindbody to empower and advocate for not only for you, but for your colleagues.
Yes, and I just want to reiterate, so if you do know that you have a benefit, you can go to kindbuddy.com/activate. If you don't, you just head to kindbuddy.com and click schedule and we'll get you started. So I want to just applaud this group because I have never seen such good questions in a session like this, and I've been on a lot of them. So I want to just start. I'm so glad that we have some time to get these answered because they're so great. So I'm going to start and I'm going to feed Dr. Jeelani a couple of your questions. And please feel free to continue to post them in the chat. And we will, in about 15 minutes, we can get through as many as we can. All right, let's start. So we touched on this a little bit, but I think it's definitely worth doing a deep dive. We hear this all the time, especially with the conversation around Ozempic right now. Let's talk a little bit about women who have PCOS tend to have higher levels of male hormones and are also less sensitive to insulin or are insulin resistant and tend to be overweight. Is that true?
So patients who in general with PCOS, was that the question, Sydney?
Yeah, women with PCOS, do they experience, it seems like are they insulin resistant and tend to be more overweight? That seems to be at the core of the question here.
So PCOS is a diagnosis of exclusion. It has really variable presentation. So the typical PCOS patient typically tends to be overweight and has an associated metabolic syndrome with it. So overweight, high cholesterol, typically high blood pressure, insulin resistance. And in those cases, stuff like Ozempic, metformin, weight loss can help. There's also a lean form of PCOS that may not necessarily have the metabolic component, but you can still have PCOS. So I'm very lean, but I do have the metabolic component. So when I was started on drugs like metformin for my insulin resistance or diet for my high cholesterol, I had to kind of balance that with making sure I don't lose too much weight because my weight didn't correlate to how my insides were doing. So tricky question, but 100% yes. In general, when you Google PCOS, you see metabolic syndrome.
Great. Thank you. Okay. Let's get this on now. Okay. So another participant has asked, I have PCOS and I've been seeing a lot about the benefits of using these weight loss medications. Okay. So we just sort of covered this. I guess this was sort of covered. Ignore me, guys. We just answered this question. So please, and by the way, the person who asked this question, if there's anything that wasn't answered, please feel free to leave it more in the chat. Okay, this we get asked all the time. I think it's a really important question. What impact does taking hormonal birth control pills have on fibroids? And I think just on fertility as a whole, an important question we get asked all the time.
Yeah. So remember, hormonal birth control is short acting, meaning it only works for that month or that period. So if you're using birth control to shrink your fibroids or to decrease your endometriosis symptoms, it will only work for that month. But if your goal is to really shut down endometriosis or shut down your fibroid growth, you need something stronger and you want to deprive all estrogen, and you want to think about stuff like Depo, Lupron, or progesterone only to shut down estrogen or not have any estrogen exposure. So I always say may prevent worsening of it, but it's really not going to help shrink it or get rid of it.
Yeah. Okay. Thank you. Okay, this question, and I would encourage the person who asked this question to join us on Wednesday with Dr. Bendixson. We're talking about recurrent pregnancy loss and doing a real deep dive there. But let's ask the question for this group. So this person has been diagnosed with both PCOS and endometriosis, suffers from recurrent pregnancy loss. Can you talk about the connection between these chronic conditions and recurrent pregnancy loss and how it can be treated to achieve a successful pregnancy?
Yes. So both of these are inflammatory, And inflammation can cause you to lose even euploid embryos. Now, we're looking at, unfortunately, if you've gone through this, you may fall under the less than 5%. That's where I fell. I have recurrent loss. I have PCOS. I've refused to get tested for endo. I know that doesn't sound as a doctor, but I knew just the treatment wasn't an option for me, so I didn't want to get tested for it. But I ended up seeing a reproductive immunologist. We can do a lot of this testing here at Kindbody, and Dr. Ben Dixon will talk about the type of testing we can do for that. But my focus was on how do I improve my outcomes through my lifestyle. So I did lifestyle modification. I addressed what can cause inflammation for PCOS. So that was my diet, exercising, maintaining low carb, anti-inflammatory supplements. I did low dose prednisone. I did blood thinners. I got tested for natural killer cells. So there's a whole slew of testing that doesn't fit the standard of care. But remember, there's not a lot of people who have recurrent loss with euploid embryo. So if you fall, unfortunately, in that less than 5% bucket, then you want to look at your whole body and to see what you can control. So decreasing inflammation through lifestyle modifications.
Okay, thank you. And I do definitely encourage this participant to join us on Wednesday, and we'll do a deep dive on RPL. Okay, so this is coming back to PCOS and ovulation. So this person actually asked two questions, and I think they kind of go hand in hand. So one of them, when we talked about ovulation predictor kits and having high LH, and so they don't really work very well for people with PCOS, does that mean that that person is not ovulating for sure, or can it be accurate? And then sort of part two of that question is talking about, discharge, vaginal discharge, and how that predicts ovulation. And is that accurate in somebody who has PCOS? Can they use that as a sign that they might be ovulating?
So PCOS is an ovulation, but not all PCOS patients who have an ovulation. I had my daughter, my second baby, spontaneously while trying to get pregnant through infertility treatment. The downside is it's harder to track. So that mucus, cervical mucus changes happens due to high estrogen. But remember, in patients with PCOS, your estrogen tends to be high because you have so many eggs there. So tracking your ovulation through LH predictor kits or temperature changes or through cervical mucus changes is hard because they're not as accurate, just given our underlying root cause that we tend to have higher LH, higher estrogen, and therefore thicker cervical mucus.
Yeah, that makes sense. And this is an interesting question. Is very painful ovulation, could it be related to any of these conditions that we just talked about?
Yes. Endometriosis typically presents with really painful ovulation. Like you can feel it. There's actually a word for it. It's called Mittelschmerz. It's pain in the middle of your cycle, Mittelschmerz. Yes, you can, endo can present with that.
Okay. What else can we pull out here? There's a lot of questions for Dr. Jeelani. Okay, let's take a look. If you know you have endometriosis, should there be a procedure done before you go through fertility treatment like IVF or egg retrieval, any piece of the fertility treatment? Should you treat your endometriosis in advance of that?
So I'm going to give you the textbook answer, and that answer is no, because remember, anytime when you go treat surgical, I know somebody else asked about surgery for endometriosis, the data shows don't treat surgically because it's going to, one, come back, right? It's a hormone dependent disorder. Two, it can decrease your ovarian reserve. Our eggs have been there forever. So treating the current endometriosis does not change the outcome for pregnancy or for retrieval because your eggs have already been impacted. There's no way to undo that. So surgery will only help. Your Mayo Clinic data and that Receptiva test is showing implantation. So if you said, I'm done, I have my eggs frozen here, my embryos are banked, and now I want to implant, and it's also super painful, can I do laparoscopy to help improve? So for the short term, in the next 5 years, it does help improve symptoms, but it doesn't really necessarily help improve your fertility or spontaneous conception.
Okay, that makes total sense. Let's pull out another one. Okay, this is interesting. Would you say that there are mental or emotional components to these conditions when you see your patient? You see a ton of patients with PCOS, really all of these. Do you see anything across the board that is emotional, mental related?
Yes, I'm going to answer for PCOS. This is something I did personally as a patient because I felt very not dismissed, but I felt like, oh, I have eggs, there's sperm, there's tube, there's a uterus aspect, it's all fine. But I couldn't understand the why or the root cause. And I'm sure endo patients feel like this as well, that if everything's functioning, why isn't this working? So there's that aspect. PCOS also have a lot of body dysmorphic disorder because most PCOS patients have metabolic syndrome. So there's a huge mental health component associated with that. Patients with endometriosis have a ton of pain, which constantly gets dismissed. And I've had patients tell me that, oh my God, I thought this pain was just normal and I just had to live with it. But this is not what everyone experiences. And unfortunately, doctors and providers can be very dismissive of that if you don't really take a chance to sit down and listen to, like, how do you track your cycle? Is pain during ovulation normal? What about these changes in my bowel habits? So in my patients who I suspect endo, I always have them keep a diary and I say, you know what, track your cycle and see if you have associated bowel symptoms, food symptoms, intolerance to certain foods, something's making it worse, because that's really how you can address the inflammatory component and know what's best for you or not. But yeah, 100%. There's a huge mental health toll that it takes on these patients. And I think it's very important with fertility in general to get plugged in and talk to somebody about it.
Yeah, absolutely. We hear that all the time that, we're not being believed. Our patients come in and say, before I came to Kindbody, everyone thought I was making this up. Everyone thought it was normal. Everyone told me, yeah, you get cramps with your period. That's normal. And being dismissed. And that really, really does take a toll. So I'm glad that we're highlighting that. Okay, this is a very interesting question. And again, I encourage this person to join us tomorrow with Dr. Beltzos. We're talking about age and how age impacts fertility and when to get tested and all of those questions. But let's talk about it quickly here. So, great question. So, how do I know whether I'm suffering from infertility versus just not having tried long enough? I'm turning 36, been trying since November, and I've got an AMH assessment from Kindbody and things look good on that end. So, this person's 36 years old, trying since November. So how do we look at age and fertility and testing, and how do we know when there's like red flag, we should probably take a look?
That's a great question. So remember, the diagnosis of fertility, you can have infertility, you can have completely normal labs. So we know age is a number one predictor of fertility. None of these labs mean anything if we don't have age to match us. If you're older than 35, 6 months of unprotected intercourse, and you're not successfully pregnant, then you need to figure out what's going on, whether it's the egg and sperm not meeting, whether there's a mild male factor, or whether there's an underlying egg quality issue. AMH is just quantity. Everyone interprets it really differently. But if you're not pregnant by now, May is your last month, and I would seek help sooner than later.
Absolutely. And now that you've spoken about quality versus quantity, I think that's an interesting question. And somebody asked here about improving the quality of your eggs if you have PCOS. How do we is egg quality something we can test for? And B, is it something we can improve?
So you can't test for egg quality. Quality is the ability to get it from retrieval or get the egg to fertilize and lead to a live birth, even if you're doing ovulation induction or conception at home. The only true test is your first IVF cycle, which is very diagnostic as it is treatment. So I always tell my patients, your first cycle will be your worst cycle with me, because that's when I'm really learning about your egg, your sperm, and how they function together to lead to a live birth. We can test for your quantity and quality. We can see if it's really, really bad. FSH sometimes can be used as a surrogate marker for your quality. So if your FSH runs really high, sometimes that can tell us it's lower quality, but it has to go really high before we know it. So it's almost like we find out when it's too late, or you learn through your first cycle. That being said, a lot of the stuff we talk about, like lifestyle modifications and supplements, are stuff to help as an add-on, but they don't necessarily change. It's not like, I always have patients ask me, like, should I take a 3-month break and then focus on my quality and then come back. And I always say, no, do it tandemly, because age and time dictate fertility outcomes. These are just supplements to ancillary help you, but it's not make it or break it.
Is it fair to say that age is really the only predictor that we have of egg quality in advance of doing any of the treatment? Is age the only really indicator that we might have?
Well,
Yeah. Okay, that's good to know. Okay, let's take a few more questions. I just want to, again, this group, these questions are really amazing. Often we get a lot that are very specific to the patient. So they're giving me like their test results and their their exact diagnosis. But this is really, these questions are great for the whole group and really apply to many different situations. So thank you. Let's talk about, this person's asking about Kindbody specifically. So with treatment via Kindbody, is lifestyle and mental health support given in tandem with the conventional medicine and treatment? And is Kindbody solely for women or men too?
So we have a male arm, so it's for both. We have a lot of same-sex males, single dads by choice. So it's for both. We do reproductive care for all, independent of sex, gender, orientation, and how you identify. That being said, we have Kind 360, which believes in mental health, nutrition, and focusing as a whole, right? And you want to use that. So I always say, if you can either plug in with us, ideally, or use your current therapist that you have. I know I talk to my patients, the first thing I tell them is, here are the supplements that I've personally studied, that I've seen good results with, that I added in. Not all doctors use supplements or believe in supplements, but I truly do from a patient end, because I was always looking for, what else can I do? What else can I add on? What can I do differently to improve my outcomes? So I truly believe that it's treating your body as a whole to improve our outcomes. And I know a lot of my partners are amazing, and they do as well.
Okay, amazing. And I just want to also say, if we don't get to your questions, you can always DM us in our Instagram account, and I will send those questions to Dr. Jeelani and get them answered for you, because we just have a very tight timeline here, because Dr. Jeelani has to see her patients. So let me ask one or two more. And I'll pull out some that are applicable to many. So one person has a question about autoimmune conditions, and we didn't cover that too much in this session, but this person has an autoimmune condition called ulcerative colitis. And can you talk a little bit about how these types of conditions might impact fertility and pregnancy?
Yeah. When you look at forget reproductive immunology, just immunology, a couple years ago, about 6 or 7 years ago, they released a statement that said that women of reproductive age with an underlying autoimmune condition tend to have diminished ovarian reserve and a higher miscarriage rate. And they actually, in their statement, said that we should advocate for egg freezing and embryo creation, because they've noticed accelerated ovarian aging. That being said, when you have an underlying inflammatory or autoimmune condition, you're also at higher risk of miscarriages. So for my patients, I proactively put them on a baby aspirin. I always talk about, if you bleed, let me know, but it's supposed to improve pregnancy-related outcomes as well, like lowers the risk of preeclampsia.
Okay, amazing. And here's one more question. We touched on this a lot at the beginning, but I just want to reiterate, because this person's asking specifically about exercise. Can you talk a bit about how weight loss can impact the success of fertility treatment? This person is specifically asking, do you encourage exercise like HIIT? Should weight loss be the drastic to help get pregnant? Is it something that really will impact your success?
So weight loss does not change your fertility. So I tell patients this, because I don't want you to blame yourself for what you're going through, right? Reduction of your BMI by 5 to 10% can help implantation and prevent miscarriages of euploid embryos. But as far as your egg quantity and quality, weight will not impact that. So it's not getting pregnant, but it's staying pregnant. In patients who we've done transfers on or failed transfers and they're overweight, we can improve success of a transfer by losing weight.
Okay, amazing. Thank you all so much. And thank you, Dr. Jeelani. We will, if we didn't get to any of your questions or if something comes up after this and you want to ask it, please send us a DM on the KindBody Instagram account. And again, we do encourage anyone who answered, we had a few self-evaluation quizzes in this session. If you answered yes to 2 or more of those questions, we really encourage you to come in and get tested, have an evaluation, have a consultation with one of our KindBody physicians. We are across the country. You can check out kindbody.com and look at our locations and find where we are closest to you. So thank you, Dr. Jeelani, and happy National Infertility Awareness Week, everyone. Thank you for joining us, and we hope you join us the rest of the week. Bye, everybody. Thank you.